All right, welcome back, everyone. It was very interesting during tea break when I come and say, hi, guys, and then somebody's like, we are back. So it never hurts to say hi back. Anyway, that's on a light note. So when you see my face, that's your sign that time is up. Let's get back. So I hope the breakout sessions were amazing and you had a good tea break, even as you got to connect with someone. I hated to break the parties, but I promise you that we'll have enough time during lunch hour and even at the end of the event to connect with someone. So the breakout rooms are bustling with ideas, insights, and interesting perspectives, and maybe a few healthy debates. We are now moving into the rapporteur briefs from our 3 breakout sessions, a chance to hear what each group explored, learned, and envisioned for the future. So before we hear the highlights from our breakout discussions, I want to take a moment to sincerely thank all the incredible session chairs and panelists. Let's give them a round warm of applause. Great. So now I'll welcome our session chairs to the stage to share their key highlights. And I know there's a bit of pressure to summarize all the rich discussions, but we will be able to look out for the final official report that will capture the entire essence of the discussion. So no pressure. For now, we just want to hear those big ideas, the reflections, or the key takeaways that stood out in your rooms. Let's begin with Ms. Widi Sari, the senior researcher at Puskapa, the Universitas Indonesia, who shared this session, and we are going to hear insights from the country case studies on marriage registration, divorce registration, gender equity, and women's empowerment. So put your hands together for Ms. Widi, even as she gives us that debrief. Is Ms. Widi in the room with us? All right. Who is available who was a moderator who is still in the room? Let me read out Elgone. Professor Sophia, are you in the room with us? Awesome, great. So Professor Sophia handled Elgone. The theme was on counting her in, addressing disparities in female death registration for improved equity, rights, and public health. Let's put our hands together when she gives us the debrief.
Hello, everyone. We had an excellent session, and may I say we had some technological challenges along the way, but there was, I think, an excellent feeling, excellent presentations on research, and excellent presentations from our government partners as to how this research is actually going to make a difference. We heard in particular in terms of Bangladesh and Cote d'Ivoire. And what I would say is that what was really clear, I think, for everybody was that this work is incredibly important, and in some ways it's just beginning. In some ways we've known for a long time about the fact that deaths are not being registered for women in the way that they should be, but to actually understand from hearing these presentations the reasons why, and to understand how many commonalities there were across countries was incredibly important. And most importantly, from our government partners, to hear how they were actually going to be able to take these recommendations and move them into action. And so I guess the last thing that I would just say is that even as there's a lot of work to do, there's a lot of solidarity across countries about what the issues are and about what we need to do going forward. And it was a pleasure to chair that session. Thank you.
Amazing. That was short and sweet. Thank you so much, Professor Sophia. Let's appreciate her one more time. Great. So a debrief to remind us that the absence of data is never neutral. It's a silence that echoes injustice. So next we have Ms. Widi? No. Okay. All right, the third session on advancing universal registration across the life course via partnerships with community-based institutions. Let's give it up for Ms. Myra.
Thank you. Again, we had a most interesting session. We had only one speaker, but he made up for the 2 others. We had Mr. Daniel Mawe. He is the, wait a second, here. He is the Assistant Chief of the Ministry of Interior and National Administration of Kenya. He's with us here. He was in the video. And we ended up talking a lot about registrations of deaths in particular and causes of deaths and the role of women and community organizations and religious organizations in helping the administrative officers and the assistance officers in doing this. It was very clear that one of the issues that came out that was very clear is that the life course perspective is very important because it's very interrelated, having a birth registration, marriage, and death. The issue also of the different types of family structures were brought up. In polygamous families, what happens when the husband dies, and the wives, who gets inheritance, how does the government ensures that there's equal distribution, at least of death certificates, that everybody knows and has a copy of the death certificates. So anyway, overall, I think there were many community-based issues and gender-based issues that are particularly related to the registration of deaths and causes of deaths, and marriage registrations also that were brought up. So thank you very much.
Incredible. Thank you so much, Miss Myra. Let's give her a round of applause one more time. Yes, what stands out from that session is that community partnerships and the side story, they are the system's backbone. And basically, systems change. They don't change when or begin in boardrooms, but it begins in communities that choose to care. So thank you so much for that session. You're going to hear from session A, or rather the first session that was here at Elgon D, country case studies on marriage registration, divorce registration, gender equity, and women's empowerment. Miss Widi, are you now in the room with us? Let's give it up for Miss Widi as she gives us a debrief. Thank you.
Yes, thank you very much. So the session 9A, it was really interesting. So we discussed a lot about marriage registration system. It starts with Djibouti that discussed its dual legal frameworks, where religious marriages like Islamic marriages also happening. So Muslim marriages and civil marriages are those two things happening in the country. From Cambodia, also present a really interesting case how Cambodia actually, the Ministry of Women Empowerment leading the cross-sectoral collaboration in strengthening gender in CRVS. So they also did a lot of work on that. And Uganda and Malawi also present a very interesting case on how actually they try to register different cases of marriages, including customary and religious marriages. So a lot of technical discussion happening as to how actually these countries registering this type of marriages and what are the challenges. And also regarding the marriage registration, I think we also discussed the importance of digital transformation and integration to make it the registration seamless and easier for the data recording. I think that's the summary of the 9A marriage registration. Thank you.
All right, thank you so much, Ms. Swedi. You've reminded us when legal identity meets gender justice. registration stops being a process and becomes protection. So let's give it up one more time for the LGD people. All right, so we're going to transition into session 10 that reads towards implementation science and operations research for CRVS strengthening systems. For those joining us online, a reminder that we'll also have a question and answer moment, including the people in the room. So please take notes, and also we'll be reading out some questions from the online people. So we will look forward to that discussion. And so to officially get us started, we have our session chair, Mr. Benedict Light, the Senior Advisor, Family Planning Branch, UNFPA. I'll welcome him on stage to invite the panelists and lead us through this very exciting conversation. Let's give him a warm round of applause even as he joins us on stage. Please clap until he gets on stage. Keep going, keep going, keep going, keep going, keep going. The floor is yours.
Good morning. So session 10, towards implementation science and operations research for CRVS system strengthening. My name is Ben Light. Thank you for the introduction. I'm Senior Technical Advisor here at UNFPA's headquarters in Nairobi. This has happened over the last month, so many UNFPA colleagues have relocated recently. I should stress, I am not a CRVS expert or practitioner, but I am a public health practitioner, and I have deep vested interests in the CRVS and gender agenda. That's not easy to say. We have about 90 minutes for this session. We plan to use the time approximately as follows. So 30 minutes for 2 presentations, 30 minutes for a panel discussion, and in the remaining time, we will have a moderated questions and answers session with you, the audience. As we begin this session, it strikes me how very foundational CRVS is to everything that needs to happen in public health, and how important CRVS is to ensuring the provision of health care where and when it's needed. Without CRVS, too often, we are quite simply flying blind. UNFPA works with governments to promote a life course approach to CRVS, and clearly a lot more is needed if we hold front of mind the findings that, as I understand it, about 60% of births and about 40% of deaths are not registered worldwide. And this is without even considering lower registration levels regarding other key interventions during the life course, such as marriage, divorce, etc. So for someone looking at this issue from the outside of the field, CRVS is absolutely crucial. Now briefly, the session is focusing on achieving universal legal identity within and across different countries, and acknowledging that this requires a customized approach that adapts to differences in political, legal, geographical, and social contexts. As such, a one-size-fits-all approach to universal legal identity is simply not feasible. In order to understand how best to strengthen and sustain CRVS systems that are gender transformative and inclusive, we need to understand what works, when, where, and how in terms of CRVS system strengthening. This session aims to explore how the CRVS system strengthening field might benefit from operations research and implementation science that tests the feasibility, efficacy, and scalability of different policy, programmatic, and technical interventions to advance universal legal identity. The session will review how operations research and implementation science has been harnessed by program managers in the fields of HIV prevention and treatment, reproductive and mental health, as well as poverty reduction. It will also review insights from the Global Financing Facility's results-based financing of CRVS systems improvements. The structure of the session will be as follows. We'll begin with 2 presentations of approximately 10 minutes each from colleagues outside the field of CRVS system strengthening. These colleagues will share insights of how operations research and implementation science has been used in a variety of fields, ranging from reproductive, maternal, newborn and child health, RMNCH, HIV/AIDS, and a few others. We'll then bring in 2 additional colleagues to explore via a moderated panel discussion how these lessons from other fields might inform evidence-based feasibility testing and scale-up for CRVS system strengthening. Time permitting, we will round out the session with interactive questions and answers and a moderated discussion with our symposium participants, you in the room and those online. So let's get started. So our first presenter is Samuel Oti. Dr. Oti is a senior program specialist at the Regional Office for Eastern and Southern Africa of IDRC, the International Development Research Centre of Africa. His background is in clinical medicine and public health. Sam's expertise spans pandemic preparedness and response, sexual and reproductive health, climate-resilient food systems, One Health, and the use of artificial intelligence in health. He's a fellow of the Royal Society for Public Health of the United Kingdom and co-founder of the Network of Impact Evaluation Researchers in Africa. I'd also like to acknowledge and underline the very close and fruitful relationship that we in UNFPA have with IDRC. IDRC, of course, not only founded and incubated the Centre of Excellence for CRVS Systems, that's now based at UNFPA, but also has been a global leader in advancing the link between evidence, policy, and programmatic impact across international development and global health. And I should stress that this session is emblematic of just how profound, deep, and widespread IDRC's contribution is to this field. The Centre of Excellence, UNFPA, and its partners have not only greatly benefited from the general financial support to the CRVS and gender agenda, but also greatly benefited from IDRC's strategic positioning of the CRVS and gender within the Global Financing Facility for Women, Children and Adolescents, and from IDRC's thought leadership in strengthening the knowledge and practice base for the global development community. So, a very heartfelt thank you. Sam will present to us on how operations research and implementation science shaped health systems, strengthening and digital innovations across Africa. Sam, if you could join me on the podium, I will hand over to you, please. If we can give Sam a hand.
Thank you, Ben. Good morning, everyone. My name is Sam Oti, Senior Program Specialist with IDRC. Not by any means a CRVS expert, but a privilege to be here nonetheless. So I'm going to talk about implementation science, operations research in the context of health system strengthening, and some of the lessons that we've learned in our programming as Canada's International Development Research Centre. How do I change the slides? This one? Let's see. What am I pressing here? Let's go. All right, and that's the title. But how did it move? Looks like it has a mind of its own. Great. So a little bit about IDRC. We are a Canadian Crown Corporation, so think of us as a government parastatal. Over 50 years now, we've been funding research for development in the Global South, led by the Global South to solve issues, development issues in the Global South. We have a 10-year strategy for the first time in our history. We've typically had 5-year strategies, but since 2020, we've had a 10-year strategy that has 3 pillars. Investing in high-quality research. So research is what we fund. We are a science funding agency. Sharing that research, the findings that emerge from that research for greater uptake and use. And then mobilizing impact, for example, mobilizing alliances for impact, for example, our partnership with UNFPA on strengthening CRVS systems. We have 5 program divisions: climate resilient food systems, education and science, democratic inclusive governance, sustainable inclusive economy, and then global health, which is where I sit, where our director, Montaza, sits, and our work on CRVS sits within our global health programming as well. Within our global health program, we have, I know the slide is a bit crowded, but we have 2 broad thematic areas. One, reducing health inequities in sexual, reproductive, and maternal health and other essential health services, and the other around fostering equitable and responsive solutions to infectious diseases in the context of climate change. So let's get into it, implementation science. This presentation is slightly skewed towards implementation science rather than operations research, given that that's where we have most of our experience. And I recognize that there are people that don't have any experience in implementation science and operations research. So I'll start with an implementation science operations research 101, if you will. So if you're an expert in that area, and I say anything wrong, just pretend that it's correct. So implementation science essentially is a scientific study of methods to promote the systemic or systematic uptake of research findings and other evidence-based practices into routine practice. So the idea is that how do we integrate research findings, evidence-based practices into our everyday programming and everyday policies and everyday practice. And then there is operations research, and I think it's better described than defined. And I think there's this American physicist who's sort of seen as the father of operations research, and he calls operations research the scientific study of operations, and the operations he was talking about back then, this was in World War II, were related to the army. Initially to the army, so how to feed a big army, how to allocate military assets, etc. But that has since broadened to a variety of fields, including health. And it's really the discipline of applying advanced analytical methods, mathematical modeling, simulation, and game theory, etc., and applying that to help decision makers make better decisions. Now, if that's still confusing, I think the next slides will explain it a bit further. So operations research and implementation science, they're really seeking to close a gap. First, the no-do gap, the gap between what we know and what we actually do. So we know that things work, but why aren't they working? And that's what implementation science is trying to address. And operations research is like, we're collecting a lot of data, but how come we don't have information? We don't have insights. There's a gap somewhere, and how do we bridge that gap? And that's what operation research is trying to fill. So for example, the no-do gap. It is clear that emergency obstetric care, for example, saves lives, saves mothers' lives, saves the newborns' lives, but many health facilities in parts of the developing world don't have the capacity to implement emergency obstetric care. So what's happening? The evidence is there. There's no issue about the evidence, but why aren't these facilities implementing what the evidence says? So that is an example of a no-do gap. A data info gap is when you have, let's say, a district health authority that collects routine health data. So it has tons and tons of data, but yet that data is not really informing its programming. There's a gap there. There's data, they're data rich, but they're information poor. And this is where operations research tries to bridge that gap. And I think these two, particularly implementation science, it emerged from a history of researchers thinking that if they build it, people will come. In other words, if you publish a great paper, the policymakers are going to read it, the practitioners are going to read that paper, and they're going to act. This was maybe 20, 30 years ago. right? Or people thinking, let's collect as much data as possible, that's the most important thing, and people are going to analyze that data by themselves and make sense of it all. So that was the thinking maybe 20, 30 years ago, but of course, with time, and today we now know that that is not true. It's not enough to just publish a paper and expect that that's going to influence policy or influence practice. And in fact, there was a study that in the public health field that found it took an average 17 years from the time you publish a paper to when that paper gets into the findings of that paper get applied. It took an average 17 years. Now, implementation science, operation research, if you look through the literature, there are over 200 frameworks, and I definitely can't go into them. But these are two examples. On the left-hand side, you have an implementation science, where implementation science sits in the broader context of research. So you have basic studies like effectiveness studies, but what implementation research does is that now that you know that a program works, how do you make it work? And that is really what implementation science is all about. How do you reach the targeted population? How do you know that your intervention works? How do you develop the institutional support to ensure that your intervention is implemented? And how do you ensure that that implementation is delivered properly? And then how do you integrate that intervention over time and make it sustainable? So I'll give an example of one of our flagship projects that ended a few years ago. It's called IMCHA, Innovating for Maternal and Child Health in Africa. And the rationale was this. We know what works to prevent maternal and child deaths. We do, for the most part, we do. Yet in sub-Saharan Africa, maternal mortality is still quite high. Infant and child mortality is still quite high. Why is that? Even though the scientific evidence is clear, why are we still having such a high burden of maternal mortality and child mortality? And so this project, or a bigger program, the idea was to sort of address the critical knowledge gaps and increase awareness amongst decision makers in terms of what works to reduce maternal and child death, to build capacity for research on this topic, implementation research in particular, on this topic, and ultimately influence policies. And this is what IMCHA looked like. And again, the slide might be a bit crowded, but it was funded by 3 donors: IDRC, the Canadian Institute for Health Research and Global Affairs Canada, about over $30 million over an 8-year period. There were 19 implementation research teams, almost 30 projects, and then it covered 11 countries across Africa. And some of the interventions that were implemented include community-based interventions, and I'll give a few examples of those, policy changes, and some upgrading of facilities and interventions at the facility level, all towards improving maternal and child health. All right, so these are some of the totals, lots of projects. And here are some of the outputs or outcomes from that in terms of the impact. For example, in Tanzania, as a result of the project, the Ministry of IMCHA, the Ministry of Health adopted an e-learning curriculum on emergency obstetric care that had been developed by the research team. And they scaled it up to 320 health facilities across Tanzania. In Malawi, they trained health workers on what is known as kangaroo mother care, and they succeeded in increasing the adoption of this life-saving practice by about 30%. And in Ethiopia, there are maternal waiting homes that they upgraded, and they found that it addressed gender barriers and encouraged women to come in and stay there for 2 weeks before labor, and then they were more likely, as a result, to deliver their children or their babies in a health facility. And this is an example of one of the health facility, of the waiting homes that was built as part of this implementation research project. Another example of implementation science in action is IDRC's investments in vaccine R&D across Africa. We know that Africa faces more public health outbreaks or emergencies than any other continent in the world, over 100 significant incidents annually. For example, we had the Ebola outbreak in 2013 in West Africa that killed over 11,000 people. And even now, we still have an Mpox outbreak in parts of DRC. And so health systems across the continent are quite fragile. And so IDRC and other partners, Canadian partners, came together to try to do something about this, and particularly in the space of deploying vaccines when there are no vaccines that are known for a specific outbreak, and deploying vaccines in the context of that outbreak. And that's part of the process of finding a solution to addressing that particular outbreak. And I think it's better illustrated with the journey that we've had so far in terms of how we've advanced vaccine R&D for the Ebola virus. So back in 2013, when there was the Ebola outbreak in West Africa, it was the Zaire strain of the virus, and there was no vaccine at the time. Now, by the time a clinical trial was set up to test that vaccine, it took about 2 years. And we all know what happened in that time. Over 11,000 people died. But eventually, a vaccine was developed. It's known as Ervebo, and that's now the cornerstone of Ebola control. But fast forward to September 2022, and by the way, IDRC and the Canadian partners were involved in that first clinical trial back in 2015. Now, fast forward to September 2022, there's an outbreak of the Sudan strain of the Ebola virus in Uganda. Fortunately, by January 2023, just a few months later, 2023, yes, a few months later, the government of Uganda had found another way they controlled the outbreak without the need for a vaccine, right? But again, it took about 4 months for the clinical trial to be set up. And in that time, I think over 50 people had already passed or had already died. And then just earlier this year, there was another outbreak of the same Sudan strain. And I'm mentioning the different strains because the Zaire strain has a vaccine, and up till now, the Sudan strain doesn't have a vaccine, and they're both deadly, relatively. And it took only 4 days for the clinical trial to be set up. And that has been celebrated as a big success, that for the first time, in record-breaking time, a clinical trial was set up, and that trial is ongoing. Now, what changed between 2013, between 2022 and 2025? It was basically implementation science. That once the trial was set up, the research team spent the time doing things that are not directly related to the clinical trial itself, in terms of capacity strengthening, in terms of getting regulatory approvals from the different authorities, what they call pre-approvals, so that in the event of an outbreak, they can respond very quickly. So they were responding to the needs on the ground and not just implementing a pure clinical trial, because they figured out if we do that, based on what has happened in the past, we've not been able to respond quickly. But if we have a more implementation-focused orientation, now we can identify some of the barriers that stop us from responding quickly. We can anticipate what they are, we can respond to them, and then we can deploy the trial quickly. And that was exactly what happened. So I'm going to stop there. I see my time is up, and I'll talk about, in the panel session, I'll talk about some of the specific lessons that we've learned in terms of implementing operations, research and implementation science in our programming. Thank you very much.
Thank you so much, Sam. Our second presenter is Professor Imelda Okiro. Professor Okiro, if you could join us on the stage, please. And actually, I'd also like to invite our 2 additional panelists to come up too. My UNFPA colleague, Willis Odek, and my UN colleague, Tanya Sayerson of ESCAP. Please, if you can join us on the stage. Okay, I think. Professor Okiro is Senior Wellcome Trust Fellow and Head of the Population and Health Impact Surveillance Unit of the Kenya Medical Research Institute, and specifically at the KEMRI Wellcome Trust Research Program here in Kenya. Professor Okiro has over 18 years of population health experience at country, regional, and global levels. Imelda's current work aims to understand determinants of health transitions and vulnerabilities at fine scales, to evaluate healthcare access and work to develop the science around using routine health information across Africa, and to embed the use of evidence for country-level decision-making. Professor Okiro will make a presentation on efforts to advance operations research and implementation science to guide public health policy and action. Imelda, a warm welcome. The floor is yours.
Thank you, everyone, and thank you for the introduction. So, as you've heard, my name is Imelda Okiro, based at the KEMRI Wellcome Trust. KEMRI is the government-appointed research institute to do research to support government interventions, but also to inform evidence-based policy and practice. So our core mandate is to do research that directly relates to what the government is trying to do. And the work I'm going to present today is by no means a single effort, so it represents the work of everyone on my team. So I just happen to be the person presenting today, but it's the collective work of everyone on my team. So Samuel has done a really good job in explaining the difference between operations research and implementation science, so I'm not going to belabor that point. But then just to say that we are trying to understand why some health interventions succeed in some places and not in others, given that it's the same thing you're doing, it just doesn't work in the same way. So I'll go through a series of different examples that illustrate what we have been able to do using mostly routine data. So that's DHIS2. This is the health information platform that most countries in Africa use, and a combination of demographic health survey data. So really we are using and leveraging secondary information to answer many of the questions that I'm going to present to you today. So the first example is some work we did to try and understand whether spatial accessibility had an impact on the uptake of health interventions, in this case, immunization. So what I'm showing there are two maps. The first map is showing travel time from where you live to the nearest health facility that provides vaccinations. So the panel A is walking time. So assuming that you have no access to motorized transport, so how long does it take you to walk from where you live to the nearest facility? The second panel B is a combination of walking and using some form of motorized transport to get you to the same facility. Green shows good access, red shows poor access, and the colors in between are on an increasing scale. So what this shows you is that there's a lot of geographic disparity in terms of access across the country. So the next thing we have tried to do is look at the accessibility and link it to the coverage of immunization. So this is a composite of what I've shown you before, except now it's showing the percent of the population that live within 1 hour to the nearest facility that provides vaccination. So red means a lower percent of your population live within 1 hour of the nearest vaccinating facility, and green means a higher proportion, 90%, live within 1 hour. So when you compare this to vaccination coverage on the right, what you're seeing is that there's a direct correlation between access and vaccination coverage. So when we did this in terms of a statistical evaluation, we found that children living more than 2 hours were significantly less likely to be fully immunized. So in terms of what you do as government, you want to try and think about how do we improve access to vaccination sites in these places that are hard to reach. So you may be thinking about mobile vaccination clinics or having vaccination days in schools or something where parents are bringing their older kids and can bring in their young kids to get vaccinated. The next example is some work we did with UNICEF, which was mapping gender-related barriers to immunization. So this is a proof of concept to understand whether there's a correlation between the evidence research group's indicators for gender-related barriers and whether those influence immunization. So they have 4 proxies for gender-related barriers. There's health literacy, there's women's status or decision-making ability, so their agency within the home, and then physical barriers. It has been shown that women are more impacted by physical barriers than men, and that the primary caregivers who typically take the children to the facilities. So again, these maps show you the distribution of these proxy indicators. The first is the proportion of women with no education among women who are eligible, among children who are eligible for vaccination. So the children who are aged between 12 and 12 months, are their mothers educated or not? The second one is a proxy of autonomy, and in this case, we are using access or use of contraception, which has been shown that if you're married and are able to use contraception, that is an indicator of your agency within the home. And then the last one is what I've shown you before, it's access. So what this work has tried to do is create a composite map, which is a layered map of all those indicators to identify those pockets that have low vaccination coverage and high rates of gender-related barriers. So again, related to a lot of the discussions in this meeting around gender-related barriers and how those could influence birth registration or death registration. So the middle map is showing a composite map of DPT1, one vaccine antigen, and contraceptive use. And the green shows areas that are concordant, so high and high. You're less worried about those. What you want to focus on is the red, which shows low coverage and high gender-related barriers. So again, this is the information that policymakers need to develop gender-sensitive or gender-responsive vaccination approaches. So again, it's not just an access issue. There's a gender-related barrier that is also playing a part in whether children get vaccinated or not. This is the same thing, but it's more granular and it's overlaid with the health access. So again, I think somebody mentioned yesterday that once you get to very high levels of birth registration, what you're interested in is identifying those pockets of under-registered children or under-vaccinated children. So this kind of analysis is very critical in drilling down to those population pockets that you need to focus on. The other example I have is looking at the recent implementation of the malaria vaccine. I think most of you have may be aware that there's a new malaria vaccine and it has been rolled out in a few countries. So this is showing the scale up of the malaria vaccination. The x-axis is time, time since the rollout and how that changes over time. And this is in relation to the population of children who are under 1. So your target population is every child who's under 1 that requires to be vaccinated. That's the dashed line, the blue dashed line. The black line is those children who have had their first pentavalent vaccine. So that's the vaccine that you have to bring your child into the facility for them to get vaccinated. So you've already overcome the distance or time barrier. You're in the clinic. So that's your revised target population. So out of those, the malaria vaccine has 4 doses. So the panel is showing dose 1, dose 2, dose 3, and dose 4. The last panel is dose 4. So if you look at the gray bars, you're already seeing that the attrition rate of children who get vaccine is increasing as the number of doses increase. So the malaria vaccine is given at 6 months, 7 months, 9 months, and at 2 years. Most vaccines are given within the first year of life. So the level of attrition for dose 4 is extremely high, and that will definitely influence the effectiveness of your vaccine. So what this information can help the policymakers do is try and adapt their vaccination strategy to capture children earlier when they're already in the clinic. And that's what a country like Ghana has done. So there are 2 vaccine antigens that are given over the age of 1. That's measles 2 and now the malaria vaccine. Measles 2 is given at 18 months, and it's the yellow line in the last bar. So already you've lost quite a lot of children who don't get your measles vaccine, but it's the closest antigen that you can use to change your vaccination strategy. And that's what some countries have done. So again, this just shows the power of using the information you have, interrogating it, and using that information to adopt or make decisions about policy decisions. I'll skip through these. I think my time is up. And just to show that there are several ways that you can use this information. This last example is looking at data from the health information system using different indicators of reproductive, maternal, and child health. So this shows access to contraceptions, how many women had antenatal care visits, how many had access to skilled birth attendants, the facility maternal mortality rate, and how many children have fully immunized children. So again, this is leveraging routinely collected data, but transforming it into useful information to identify pockets where you have poor access to health services, and using that to adopt your strategy to identify what you would need to do differently to improve access to health interventions. So one of the indicators here is facility maternal mortality rate. So if you have very high coverage of skilled birth attendants, your women are going to antenatal care services, but then your maternal mortality rate in hospital is still very high, then already you're seeing discordance between access to health services and your outcome. So again, this is another way of trying to identify ways in which you can improve what you're doing based on what information you have. So in concluding, I think operations and implementation science are powerful tools to identify what works where, when, and how. Some of the insights I've shown you lend themselves to a lot of the work that is being done within the CRVS space. So a lot of my current work now is trying to use the similar approaches to understand birth and death registration within the Kenya context and try and interrogate why, given the fact that everything is the same across the country, why are some places lagging behind and not others? So again, just to make the point that there are a lot of similarities and a lot that can be borrowed and applied to the CRVS and getting us to universal coverage. Thank you.
Thank you so much, Milda and Sam, for underlining so clearly why this work is so important, and for setting the scene and giving us an overview of operations research and implementation science and their combined power to guide evidence-based scale-up in public health. And now, it's my pleasure to bring in our two additional panelists. Willis Odek is Regional Advisor for Population Development and Policy at UNFPA Arab States Regional Office based in Cairo. Willis has over 2 decades of experience in research, monitoring and evaluation in population development, including technical areas of family planning, key populations, HIV interventions, malaria, nutrition, employment research, population and housing, census, surveys, health systems, and data use. Tanya Sayerson is a statistician and CRVS lead at the Statistics Division of the United Nations Economic and Social Commission for Asia and the Pacific, ESCAP. She is leading ESCAP's work in support of the Asia Pacific Civil Registration and Vital Statistics Initiative to get, and I quote, everyone in the picture. So, turning now to the panel discussion, CRVS system scale-up is complex and highly context-specific. So, Willis, first of all, your career has spanned CRVS and data system strengthening work, as well as operations research and implementation science. What challenges and opportunities do you see in adapting ORIS to CRVS systems scale up? Should we be bothering with this? If so, why? And if not, why not? The floor is yours.
Great, thank you very much. Let me just give a little bit, for 1 second, a little bit of my background. So before I came to UNFPA, I was working with a USAID, US Agency for International Development funded program called Measure Evaluation. You are probably familiar with Measure DHS and Measure Evaluation. And my work was primarily on strengthening routine information systems, especially the health management information systems. I was very pleased to see Dr. Okiro present those results. And I've continued with that in my current role. So the question you asked me, I will draw from that as well as some of the stuff we are doing. So CRVS, as it sounds, is part of the routine administrative data systems. And unlike research studies that we can usually define and confine and control factors for, routine data systems are confronted by several factors, but you can think about them in around 3 ways. You have got technical issues, you've got organizational issues, and then you also have behavioral issues. And these operate both at the levels of the service providers, but also the clients that are being served by these systems. So if you ask me about the challenges that exist, I think we've had enough of this over the past 2 days. And there's a misconception that has been coming across that these challenges are less so for birth and death, because those are clear biological processes, and more complex for marriage and divorce. But even when you look at the cause of death recording, you've got a huge discrepancy between the deaths that are reported and the cause of death. And so you should be asking yourself, why does that come about? Now, that is really the gap that implementation science and operations research would need to address in the case of CRVS. So I think we've got a great opportunity in dealing with many of the challenges that we've talked about here from an implementation science perspective by distilling those technical issues. Some of the technical issues have got to do with just how we design our data collection tools and the processes by which we collect the data. And the assumption that digitalization will ameliorate those problems is also misplaced, because we always assume that when you provide the technology, then people will take it up. So I think the opportunity for us is to gain deeper understanding as to why even some of the innovations that we have in place are not being taken up and scaled up broadly. The other one is we've also listened to a number of pilot programs. So we've had stories over the past 2 days in countries where they're even attempting to implement some of these interventions, so improving the workflow, the registration processes in pilot areas. What has not been coming out of that is the research and data collection that is built into that. Because from an implementation science point of view, you need to see these interventions from a systems perspective. So you have got a system that is designed, but when you're implementing it on the ground, you've got the individuals who are receiving it, they've got their own perceptions, they've got their own understanding, they've got their own concerns. You've got the organizational setup where the implementation is happening. We've seen just the fragmentation in the CRVS service delivery. Now, unless we are able to understand the frictions among these organizations and the best modalities for bridging those, we are not able to make a difference. So all I'm saying in short is that the CRVS as a routine data system is confronted by these practical challenges that are embedded in the context where implementation occurs. And so making success requires that we also embed ourselves in such a context. I'll conclude by a final statement. We are working towards developing a guideline for streamlining marriage and divorce registration, for example. Right now, we are dealing with that at our technical level. But in order for it to be practical and to improve the practices and uptake of those particular services, then we must also engage in more participatory-oriented research and evidence generation so that we understand what it is that motivates or disincentivizes the clients to take up some of these. So I think the CRVS area is a minefield for implementation research and operations research, and we are not doing enough of that, but we must change that moving forward. I'll stop there.
Willis, thank you very much. Tanya, the CRVS Decade of Action was recently extended and expanded in Asia and the Pacific in July, as I understand it. Do you see opportunities to integrate ORIS in the next phase of the Get in the Picture CRVS regional program in Asia Pacific, and where do you see some of the greatest potential? Please.
Thank you so much. And this has been extremely interesting, and I'm really, really pleased that we're having this session. I think we probably all struggle a little bit, right? How do we move from evidence to policies to actual impact? And I think having these discussions are crucial to move that forward. As you just mentioned, we have just in June, but close, extended the Asia-Pacific CRVS decade until 2030. Originally, when the decade was initiated in 2014, we thought we would have universal registration and beautiful vital statistics, and everyone would have documents by 2024. Unfortunately, that was not the case, so the countries asked for the extension of the decade to keep the focus on this really important issue in Asia and the Pacific. And Asia Pacific is very diverse. Yeah? We have some tiny, tiny islands that most of you probably never heard of, and we also have, China and India. So it's an extremely diverse region, which also means that we have always been very aware that a solution that works in one place probably doesn't necessarily work everywhere. And actually, already back in 2014, there was a research agenda for CRVS developed as part of this regional initiative. Unfortunately, it took us a bit of time to actually get it off the ground and start focusing more on the research and how we can get impact from research on the ground. We really want to know more about what works on the ground and gain a deeper understanding of the problems and the solutions in specific countries and specific local communities as well. And because of that, over the last few years, with support from the Bloomberg Philanthropies Data for Health initiative and together with our amazing colleagues at ECA, William is right here, we have started CRVS applied research training. And we actually have Benita, who's one of the first people who joined that initiative, where we take practitioners on the ground, so the people who are working in the National Statistics Office or the nurse who is responsible for implementing verbal autopsy in rural areas of Papua New Guinea, and we bring them through a one-year program trying to improve their research skills so that we can start getting that documentation on what works on the ground. We're still only in the second cohort, and we've actually just put out a call for the third cohort, but I do think that this is a part of the story of what we need to do going forward. We need to help the people who are really, really, really knowledgeable about their own job and what they do and what they don't do, and try to help them bring that knowledge. First of all, formalizing that knowledge so that it becomes accessible to others, but also bring that knowledge to national, regional, and also global stages. And a big part of what we do with the card is to try and facilitate that knowledge sharing beyond just the card initiative in itself, and also create little linkages between these practitioners in Asia Pacific and the practitioners who are coming from Africa and so on. To try and help with disseminating some of this knowledge and some of the other great research that is happening that just doesn't really get out there, we are organizing a CRVS Research Forum in April next year. And we've been very, very positively surprised by the level of interest in this. And we put up an open call for abstracts, and we were hoping, we would get enough to hold a 3-day forum. And we had 160 people submit in abstracts. So this shows me that there is a lot of research actually happening. There's a lot of people out there who wants to formalize what they're doing, who wants to get a better understanding of what works and what doesn't work. And we're hoping to play a bit of a role in getting that information out there. So I'm super pleased that we're having this discussion, and I'm hoping it's going to lead much further. So thanks a lot for bringing me on this panel. I appreciate it.
Thank you very, very much. So I've been informed we have a hard stop at hour, so that's in a little over 10 minutes. But we will try to get through another couple of questions, and we will take one question from the audience and one from online. But I would ask the respondents to please be brief, as possible. Willis, your current work in the Arab States region, a region that spans some of the most complex labour migration contexts in the world, and that's experiencing protracted conflict and fragility across many countries. Do you think ORIS approaches to CRVS system strengthening, do you think these approaches are relevant and even feasible in fragile settings? If you can try and give a sort of summarised response in a couple of minutes. Willis, the floor's yours. Thank you.
Great, thanks. I think I will just echo the point I made at the end of my previous intervention. There's no environment that is not amenable to implementation research and even operational research. In our region, actually, one of the critical areas that we would be seeking, what we could look at in CRVS is whether the legal framework that some countries pronounce are being implemented or not. So if you take a country like Egypt, clearly they say that they welcome all asylum seekers and refugees, and that they have a policy of no internally displaced populations camps. Now, one wants to look at that and see whether it translates into service delivery, vital civil registration and vital statistics for those particular populations, and if not, what are the barriers to that? If so, what are the enablers? And what is the level of integration that these populations experience? So in short, yes, even in complex settings like the ones across the region I am in, there's great opportunity really to understand how CRVS can be strengthened to be inclusive and to meet the needs, particularly of the marginalized populations.
Willis, thank you very much. And just briefly, Sam, if I can direct the final question for you, in a couple of minutes as possible, can you share with us some key lessons learned and guidance that you would want to share with CRVS practitioners with regard to how to advance a culture of operations research and implementation science?
Yeah, absolutely, Ben. I think the first thing that is critical is engaging the decision makers right from the get-go. I think one thing that helped IMCHA was that rather than the typical approach of asking, maybe in a call for proposals, that the applicants get a letter of support or they wait until the inception meeting or workshop to engage decision makers, we made it a requirement that a decision maker, a policy maker, has to be a co-principal investigator in the implementation research teams. And that really helped extremely with the uptake and the implementation, because at the end of the day, the underlying assumption of implementation research is that we know what works, and even the policymakers or the decision makers know what works, they just need help with making it work, right? And so you have to have them at the table right from the get-go. Another lesson was that you have to be participatory, you have to be adaptive, because most times your assumptions will be tested when you're out there implementing. You might build, for example, that waiting room for mothers and find that no one from the village, no pregnant woman is going there. Why? There might be cultural barriers, and you need to be adaptive to be able to respond to those. Then you also need to have a gender equity and inclusion lens, and also an intersectionality lens. And that's part of the beauty of implementation science, is that when you get out into the field, you find that there are barriers that are out there that you need to adapt to and that you need to respond to. And so you need to have those tools within your methodological toolkit to be able to identify what some of those structural barriers are and to respond as part of your implementation science work. And then you need to take a long-term view. IMCHA was 8 years, which is not a typical duration for a lot of grants. They tend to be 3 to 4 years on average. But again, recognizing that change takes time, implementation takes time, and being able to measure the impact of implementation takes time. And so having that long-term view. And then lastly, collaborate. We partnered with other Canadian funders. Within the research team, we had a diversity of expertise, and that helped us to slay this dragon of that no-do gap that you tend to be faced with when you're trying to do implementation science and operations research.
Sam, thank you very, very much. Imelda, same question for you. What are some of the key lessons learned and guidance that you'd like to share with CRVS practitioners regarding how to advance a culture of operations research and implementation science, please?
I think Sam has said a lot of what I was going to say, but maybe I'll just, I think a lot of times we focus on the system, so the policy makers, the systems in the policy side, and forget that there's the demand side, there's the people, the behavior side. So I think part of what needs to happen is actively engaging communities, understanding cultural norms, contexts, in the development of intervention strategies. So it can't be something that you do on the back end of a program design that has already happened. So you have to actively engage them, seek feedback, and even after rolling out the intervention, continuously evaluating to understand, is it working the way we had anticipated? And if it is not, then where is the disconnect? So it is a continuous process over time. The other thing I would say is, within countries, there are various agencies, partners that exist. So there are academic institutions, there's the statistical, National Bureau of Statistics. So CRVS is not alone in the landscape of who they can call on or leverage in terms of enhancing capacity. However, even within CRVS programs, I think there needs to be a focus on building capacity inside the CRVS to do a lot of this work themselves. So they can't outsource the expertise to partners and partnerships. It needs to exist for it to be sustainable and embedded, and for there to be a culture shift. It needs to exist within the CRVS program. So I think that is something that we need to encourage and support in whatever ways we can. Then again, maybe to just leverage what Sam had said, you have to think about implementation science and operations science from the beginning as you're thinking about how to improve certain interventions. So it can't be, you can't think about it as an evaluation process. It has to be something that you do in the program design. So you're thinking about, what are my operational research questions? What are the implementation considerations, concerns that I need to be thinking about? What is already existing and what are we changing and what is that going to happen? And then does this apply for every geography in my country, or do I need to adapt it for different places? A lot of times we do the same thing across Kenya. We do the same thing across Uganda. And Uganda, Kenya are not homogeneous. So even within counties in Kenya, there's a lot of difference. And I know it's hard from a policy perspective, but in reality, you have to design your interventions to be responsive to the context in which you're working. Thank you.
Thank you very, very much. And I think that's a very important note to finish. Design really at the lowest scale possible, and that is, as we've heard, the goal, but not an easy task. We've got time for 2 questions. Is there a pressing question in the room, first of all? Hand. That's the first hand I saw, please. If we can get a microphone. The 3rd row on the left-hand side for...
Merci de me passer la parole. Thanks a lot for having given me the floor. I expect that you're able to follow the interpretation. I want to really appreciate the presentations that have been made and the intersections that has been made between CRVS, gender and health. And the groundwork that we do, we can see that there are difficulties to progress on registering births and deaths as well. If for health, it's a great opportunity. And why do we not? Why don't we amplify the fact that birth registration is given to a birth so we've got programs that are existing that are supported by different donors. Maybe it is time that we make it clear that in these different programs that these are cares, the cares for birth and death should be sufficiently amplified in the ground where we work, so that by be extended in real time. But on the ground, when we tell somebody that are given birth, when there is death, we don't say that. When we need to declare both death and birth. So when there is death at an institutional level, we say that the person was deceased, and we also tell that there was a birth when it was declared. So that we can also be able to advance in both death and birth.
Particulier ou pas tellement?
Was the question directed to any person in particular? I think that is to UNFPA that supports that particular subject.
On behalf of the question was directed to UNFPA, so if you can respond.
Yeah, I think it's a good point. It's about just how we manage information on deaths as compared to births. Again, it needs a good understanding of the social context. In certain places, declarations of birth are done as they are done for other events, in others it's not. But I think the most important thing to highlight is the value and importance of registering births. I think in the case of death, it's a requirement that you can't enter a body without the document. So that already creates the incentive for that kind of registration. But there should be more work of engaging with society, with the society to amplify, as you rightly put it, the importance of birth registration and celebrating that as a right for the child and the parents as well. I hope that addressed the dimension you had.
Thank you, Willis, and thank you to the questioner. We do have time for one more question at the back, please, sir.
Okay, thank you so much. My question goes to Prof. Regarding the attrition rate for immunization, I would like to ask how different were those children who went out all the 4 rollouts to those who at some point did not follow up, and if there was any methodology to account for any potential bias. Thank you.
Thank you for your question. So as you recall, I mentioned we're using DHIS2 data. So it's aggregated data. We don't have individual level information. So there's very little information about the types of children. However, because the vaccine rollout was done across 23 counties, it's possible to look at differences across space, but that doesn't tell you anything about the types of children. So it's possible to do that. I didn't show you that. But I think a lot of it is driven by the fact that the vaccine is given very late in life, and most women will not come back to bring their child at 2 years for the vaccination. So for those reasons, we need to adapt the vaccination strategy or even improve the application around the importance of bringing back your child, or link it to another process. So we have campaigns for measles vaccine or polio vaccine. So maybe the delivery of the final dose needs to apply a different mechanism of delivery. But without this information, then you don't have that insight to know that we need to adapt, we need to change, and I think that's the point. So use your information to inform what you do going forward, and then continuously monitor to see if that changes or not. Thanks.
That was anything. I think we are out of time, but I would really like to thank Imelda, Tanya, Sam, and Willis very much for making this such a rich and informative session. There's clearly very much to ponder, an enormous amount more to do. I think we have to finish the session now. Thank you all very much. And I will hand back to Charity. Thank you.
Thank you so much, Mr. Benedict, for that excellent moderation of the session, and to thank our distinguished speakers and the panelists for their powerful insights and contributions. Let's put our hands together with one warm round of applause. Great. They've reminded us that implementation science and operations research go far beyond technical frameworks. They're about translating ideas into measurable change, and we've seen that when innovation is guided by evidence, collaboration meets accountability, systems don't just improve, they transform lives. A quick request before we break out for lunch. We are going to take a group photo right before we head out to Cafe, that name is Cafe Kigwa. So before we do that, I'll kindly request all of us to go downstairs. At the photo place, you're going to take a very nice picture. I know you had already taken one for day one, but think of today as the day 3. We made it to day 3. So the voices that are behind making the symposium very successful. So we're going to take a well-deserved lunch. It's 12:34 p.m. We'll be coming back at exactly 1:45 p.m. sharp for session 11. That is going to be a powerful panel discussion on advancing gender transformative CRVS systems to accelerate societal inclusion across the life course. And this session will be chaired by Dr. Ramesh. So when you come back, you'll be able to invite the panelists and give us the guidance. Please note that we intend to finish earlier at 3 p.m. so that way we can be able to give you more time to recharge, connect, and maybe even explore a little Nairobi sunshine before you leave your countries. So we'll kindly request you to be back and seated at exactly 1:45 p.m. For the online people, thank you so much for participating. We still acknowledge you. Please feel free to give us your questions for the next session. Step away from your screen. It's also lunchtime for you. I promise you that your emails can survive 45 minutes without you. But we'll be back at exactly 1:45. Now the lunch directions, you're going to have lunch at Cafe Kigwa restaurant, exactly the same place we had lunch yesterday, but now upstairs. So that's where we'll be having our lunch. And so as you enjoy your lunch, you know my assignment here, I love making people connect. I have another assignment for you. As you connect with somebody whom you've not connected with so far, this is the question you're going to ask. If you could swap lives for just 3 days with anyone in the world, in any role or sector, and everything you do in those 3 days stays permanent, it's a permanent solution or change, who do you switch places with and why? See you at exactly 1:45 p.m. Thank you.